Okay, so thank you for coming. I want to provide an update on the hospital. We did a press conference a couple of days ago, and I talked a little bit about some of the challenges we're having in the hospital. Those challenges do continue, and they do continue to escalate. We did surpass the 50 inpatient mark overnight, so we have 51 inpatients in the hospital with COVID. Again, that's about 25% of our hospital census. In addition, we are holding 21 patients in our emergency department this morning that didn't have beds in the hospital. Those numbers are not included in our daily total. Additionally, we had a patient that we had to hold in our surgical recovery area because we didn't have a bed for them either. Our staff continues to be hit hard. We had an additional 11 staff members test positive for COVID in the past 24 hours, so we now have 85 staff members out, and we don't anticipate we're going to get some of those back for a while because COVID will need to run its course for them. So again, running into a lot of challenges with staffing and with kind of addition of patients. There's a number of steps that we are taking as a hospital to try and meet this demand. As I reported Wednesday, we have entered what we call emergency command center operations, where every morning for an hour the executive team meets and we focus on the challenges of the last 24 hours and look forward to the next 24 hours and what challenges we anticipate that we are going to face. Some of the measures that we've taken, all of our clinical nursing managers have been relieved of their administrative duties and are now being assigned to bedside patient care. So we're repurposing everybody at the front lines. We have a number of nurses that serve in our organization in non-clinical areas, doing work in some departments, things like quality, education, things like that. All of them are going back to being reassigned back to patient care areas to try and meet the holes of the staff. I should add that included in those employees are out, we had 12 nursing holes today, people that were scheduled in holes that are not going to be able to show up for their shifts today, and an additional 8 NACs. So that's 20 people that we are having to try and replace kind of on the fly today by asking people to stay over, work double shifts, getting people from other places, and each day that number gets bigger and becomes harder and harder for us to accommodate. We are stopping all non-emergent surgeries, so any surgical case that will require admission to the hospital unless it's absolutely necessary, we will be canceling all those cases. That will allow us to, first of all, prevent having to admit any of those patients to the hospital, but it also allows us to float some of those nurses to other areas like the emergency department where we have greater need at this time. This is not something we want to do. This in effect kicks the can down the road because at some point we do have to double back and do those surgeries. In the meantime, we do understand that the conditions can sometimes worsen. We are stopping a lot of outpatient services that are not completely essential, and that will allow us again to repurpose some of them into the hospital in the acute care setting. Even today we have several LPNs from the clinic that are getting a crash course in our Cerner electronic health record so they can serve in some patient care areas. And then we have other plans where we will be able to get some, hopefully get some staff from the outpatient clinical setting and bring them into the hospital. We also have outpatient services that we will continue, but we will focus all of their efforts based around the hospital. An example is home health. They do take referrals from the community. As of now, they're only going to take referrals from, with the purpose of getting patients out of the hospital to free up beds for other patients. So that's just one example of some of the adjustments that are occurring. We're also looking for opportunities to consolidate services, moving some services that we provide on site and consolidating them as outpatient settings so we can free up more space and staff internally to meet this growing demand of patients. I do want to make a request. If there are any nurses out there who have either retired or are not currently working and you would like to assist with this pandemic, we do need help. And if you do have any ability, we are going to be putting up a link on our website if you go to our human resources area. And if you want to step up and help us out, we have a wide range of areas that we can plug you into, fitting with your previous training, your comfort level. And it may, at the very least, free up one of our nurses to be able to move into one of the more acute care settings. So if there's any of you out there, we certainly are willing to listen in terms of how you might be able to help us. I guess at this point I can take any questions. Yeah, Emily.
Expand a little bit on which outpatient services are going to be kind of cut down right now?
Just because we're still communicating some of these changes within our organization, I think I want to hold off on that at this time, because there may be people affected that aren't fully communicated with yet.
COVID-19 and in light of the Department of Health saying ivermectin might treat that. Could you expand a little bit on what kind of advice?
I'm sorry, I had trouble hearing that question.
When I talked to Bridget earlier today, she told me that you guys are going to be having like seminars and stuff to teach staff how to treat COVID-19 because the Department of Health recommended not using ivermectin for the treatment of it. Could you expand a little bit on that, on what were you guys going to be telling people?
I guess I'm not sure what she's referring to in terms of doing a seminar to train staff. Every day we try and update our staff on whatever latest developments they are as they come up. As I've already mentioned, right now we are providing kind of just-in-time training for job categories, so people can move into other areas that maybe they're not previously trained in. In regards to ivermectin, there's been we've gotten a lot of questions about that from media and from others. Ivermectin is not an approved treatment for COVID-19. There was a small initial study out of Australia that was done in a lab where they used very high concentrations of this drug, and it did inhibit COVID-19 in the lab. The concentrations they used in the lab would not be tolerated in the human body, and so people have extrapolated that to try and use it as a treatment. Yesterday, the health district put out a formal warning about the use of ivermectin, especially in our society where we do have a large equestrian community, people who work with horses and hold horses. We also have a lot of livestock in the area. This is a medication. It's actually an anti-parasitic medication. So it's actually used for things like head lice and then a couple of intestinal parasites. It's not an antiviral medication. But people have access to it, and one of the dangers is that when they make, there is a human formulation for things like head lice and a couple of GI parasites, but the formulations are different. And if you take the veterinary version of it, it is not a human formulation, and it can cause a lot of problems, including a lot of side effects, low blood pressure, nausea, vomiting. It can even cause liver failure if you're not careful. In fact, patients that are on it long term, one of the things we have to do is we do have to periodically check their liver tests and make sure it's not causing problems. If you're on blood thinners, it interacts with your body's metabolism of those blood thinners and can make your blood way too thin and put you at risk for bleeding. So it's something you have to be very careful about. And again, this is an example of where a small piece of kind of laboratory-based study has kind of been embraced by certain people and made to be sound like it's a miracle treatment. And this is one of those things that just blows my mind again, that we have this vaccine with over almost 200 million doses given in this country with essentially no long-term side effects at all. And proven to prevent hospitalizations, proven to prevent deaths, now approved by the FDA, and people still are refusing to accept this as a treatment and then seeking out these treatments that are potentially harmful and show no proof that they work.
Have you guys had anyone come in with symptoms or side effects from the ivermectin?
Yeah, honestly, I don't know the answer to that. I know we've had patients show up who have been prescribed ivermectin or have taken upon themselves to take it. So this is something that we're seeing in our community. I can't say whether we've seen anybody that's gotten into trouble from it. In general, in human formulations, it is generally a pretty well-tolerated medication. But if you're not taking it as prescribed by a doctor, it's pretty easy to take too much of it, especially if you're using any veterinary formulations. If you think about it, a horse weighs literally a ton more than a human, and so it's very easy to cause a lot of side effects.
And why do you think that these people are getting symptoms?
I can't say. I've had doctors approach me about that. They're very concerned about the trend. I don't know who all is prescribing. I do know that not everybody reads the same literature, I guess. But I will say that if there's doctors out there using not only non-proven treatments, but treatments that can be harmful, and especially now that there's been a formal warning about their use, they do run the risk of being reported to the licensing agency here in the state of Washington, as they have in many other areas. We do see briefs of other states where they face this, and there have been cases where other state agencies, I can't speak for ours, but where they've taken action on people's licenses for either spreading misinformation or prescribing things that are harmful. So you just need to be very careful if you're going to prescribe things that are kind of experimental and whatnot. They're very careful that you're consenting patients properly and that you're not doing something that's potentially harmful to them.
You mentioned the vaccine. Recently, a statewide survey was done to ask people why they're not taking the vaccine, and some of the reasons were they're worried about the side effects, they're waiting to see if it's safe, they don't trust the COVID-19 vaccine, they don't trust the government, and they don't believe that they need it. So what would your direct response to those reasons?
Well, whether you need it or not, your community needs it. If we don't stop this, if we don't get shut off the flow of patients in this hospital, people are not going to get the care they need. And that's not just for COVID, that's all medical conditions. Again, I've already said that we're going to be stopping a lot of the surgeries that we've been doing. A lot of other organizations have already done this. We tried not to do it, and we're not completely shutting down, but we're certainly really looking hard at the cases we do and making sure that they're absolutely necessary in the short term. But that's because of this pandemic, and because we have to conserve our resources, the staff and the space and whatnot for the patients with COVID. So our community needs people to step up and prevent the spread of this. So that's one. Two, it is safe and effective. I don't know how many different times I can say that. The medical experts all over the country agree. The FDA agrees. We've given almost 200 million doses. There's 11,000 plus people a day across the country being admitted for COVID. Even if there is a random bad side effect here and there, the risk-benefit ratio tips so far in the favor of the vaccine that it's not even a discussion. I don't know what to say about trusting the government. I don't say. I mean, people have their trust and their mistrust, and I'm not going to change someone's mind if they don't trust the government. But I can tell you that your risk of having something bad happening is way higher if you don't get it. Did I answer all of them, or was there one of them that I missed?
Side effects, they don't do they need it, waiting to see if it's safe, don't trust the vaccine, don't trust the vaccine.
Yeah, let me just talk about side effects a little bit, because I happen to be one of the people that had a little rougher time with it when I got mine. Most people tolerate it, it's not a big deal. They're back at work and like, it's fine, didn't feel anything. But there are some people who get these side effects of the immune response. And again, the purpose of the vaccine is to stimulate an immune response. So you will get symptoms that mimic having the disease, but for a very short period of time. So you'll feel achy, you just feel a little off. Some people actually get some low-grade temperature, stuff like that, but it's very short-lived. And what really surprised me when I went through it is how quickly it just shut off. It was there, I had it for a few hours, and then just as quickly it was gone, then I was completely fine. So yeah, you may be one of those people that gets some side effects. That's normal, and actually that's a good thing, because it tells us that it's doing what it's supposed to, that your body is learning this thing so that when it's faced with the real thing, it knows how to fight it. So you may have to deal with a few hours maybe, because again, I've talked to plenty of people who had zero side effects. In fact, both my parents, my wife, none of them had a problem with it at all. And I think that's more the common one.
And I know at the last press conference you mentioned that you had at least 13 patients waiting in the ER for care. How many did you have waiting today?
I think that you mean in the waiting room?
In the waiting room.
I think the numbers actually, in a lot of times, it's over 30. So I talked to the doctor, the ER doctor who was covering the ER not last night but the night before, and we had a particularly stressful night. Again, they were holding 21 patients, so they were seeing patients not only in hallway stretchers, but they literally just brought in just plain chairs and actually had ER patients sitting in chairs in the hallway and seeing them there. They had a patient with a really serious medical condition came in by ambulance, and they didn't even have a bed or a room to put them in. And so they had to just manage them right there on the paramedic stretcher and then move them into the hospital. These are really dangerous situations, and this is not how we want to care for patients. But she said, well, all that was going on while they're seeing patients in chairs and whatnot. Well, they've got 21 patients that need beds that don't have them. They had 37 people sitting out in the waiting room. Those are people, we don't even know what's wrong with them. We've kind of asked them the preliminary questions, and we've tried to pick out the ones that look sick or have abnormal vital signs or have particularly serious complaints and get them back. But again, when you're already seeing patients in chairs, you just don't have a place to put them or the staff to see them. And so you have no idea what those 37 patients are. They could be having a heart attack out there and you'd never know it.
The last time we spoke, you said you had enough oxygen. Is that still the case?
Again, that's something we have to monitor day to day, actually hour to hour for that matter, as we kind of, patients' oxygen requirements change, on a regular basis. And so we're constantly having to pay attention to that. Like I said, we did a few days ago reach a point where we had to resort to using oxygen tanks. Fortunately, it was very short-lived. We're still able to have everybody just on our wall supply that's all wired through the hospital. But it's something we do have to watch very closely. And that is one of the concerns if this gets any worse, that we just won't have that infrastructure to be able to handle that.
And what do you have to say to people who don't believe in the hospital?
I don't know what my gain is by being out here telling you all this day after day. I don't know how. I can't get a group of doctors who work in the same place, who socialize together, who are friends, to agree on the same thing when it comes to taking care of patients sometimes. And this idea that every CMO in the country, every organization in the country, and it doesn't take you long to go to YouTube and see that other CMOs doing exactly what I'm doing right now, that we've somehow all coordinated a message saying the exact same thing. I'd love to know who put that one together, because they should be our president, they should be king of the world, and maybe they'll kind of coordinate that kind of response. It's just not possible. I'll ask you, how can we make this real for you guys? How can we, what's missing? What can we do to really get you guys to feel what's going on here? Unfortunately, there are federal privacy regulations that prevent us from just letting the cameras go in the hospital and taking pictures of patients. So we do have federal regulations that we can't just give carte blanche ability to go in and start filming stuff. But I don't know what else I can say. I can get other staff members out here to talk to you. I just don't understand what our gain would be in manufacturing a crisis. We're not making any money off this. We get our money off doing, you make your money off doing elective surgeries and stuff like that, and that's exactly what we're stopping. So there's no financial gain here.
Another idea might be, you mentioned like having other staff members talk, maybe hear from some of the nurses that are out there, with your so short staff, and you mentioned that they might be seeing more patients than usual. That could help.
Okay. I'd be happy to find some frontline nurses for you to talk to. I think that's a great idea.
You can go first.
We kind of promised already before I asked most of the question that there's another freedom rally scheduled for tomorrow afternoon in Chestnut Park. And people are protesting the mask and the mandate, and Mark was saying, COVID's a hoax, and you don't take away our rights or freedoms. You kind of talk about this already, but if you get a chance to talk to some of these protesters who think this is all whatever, what would you say to them?
I think back through how our nation was formed, and the number of times our country had to come together to build it into what it is. And we did this to ensure our freedoms, freedom from taxation, freedom from a foreign government telling us what to do. But in order to get those freedoms, we had to agree to band together for the common good. That's how we got here. Personal freedom does not, in my mind, if you really look at the spirit of how our country got to where it is, it wasn't because people said, you can't tell me what to do, I'm doing my own thing. When the British invaded, people stepped up and they went and fought. You were making a choice for them. And by doing that, you were putting the safety of this entire community at risk because of the impact that it's having on this hospital.
And to follow up on that, because when I talked to Dr. Davenport mentioned it last about most of the hospitalizations, you guys are seeing it because people are not vaccinated and or not wearing masks. Is that what you're seeing still at this time? Yeah,
unfortunately with the Delta variant, it's definitely more transmissible, and we are seeing some leakage through the vaccine, but it's about 90%, 10% roughly. That's kind of what we're seeing, and that's what we're seeing in other places in the country. So it's not quite as good as it once was, but I can also tell you that most of the vaccinated people that are getting admitted have a lot of other health problems. So these aren't your young, healthy people. These are immunocompromised patients who are morbidly obese, have high blood pressure, diabetes, heart disease, a lot of what we call comorbidities. Those are the people that are having trouble even though they're vaccinated. When we see the young, healthy people having trouble, those are uniformly unvaccinated individuals.
The Board of Health came out saying, or sending messaging to the governor asking him to, not require masks in schools, and also recommending that he choose some sort of alternative to mandatory vaccination for the healthcare sector. Have a response to that and see if that's something that we can do.
Yeah, I watched the meeting and I listened to the discussion, and I get the point of not wanting to have to mandate something like this. In leadership, you learn pretty quickly, or you don't last in leadership, that if you go around telling people what to do, it doesn't always go over well. There's times you just have to do it, and that's part of being a leader too, is understanding when do you try and lead by example, lead by inspiring them, and then when is it time to say, look, right now, we just need you to do this, and so I'm going to tell you. It's kind of like being a parent. You want to kind of coach your kids to do the right thing, encourage them to do the right thing, but there's times like when you're on a busy street or something where you get into that command and control and you say, you need to do this or you can't do this. What I can tell you is, Governor Inslee came here in May and met with some of our staff over here, and I think some of you guys covered that because I'm pretty sure it was in the media. And at the time, he asked people, what can we do to encourage people to get vaccines? He wanted to encourage people. He wanted to work with people. He wanted to try and find incentive. He wanted to convince them to do the right thing for everybody. He did not want to have to get to this point. But now what he's seeing and what we're all seeing is only 43% of Yakima is fully vaccinated based on the last statistic I saw, and we are in crisis. And we have to do something. We're at that point where it's now command and control. It's like if we don't do something drastic right now, we tried education, we tried to make it easy for people, we tried to convince them, it didn't work, and now we're paying the price for that. So now we have to go to that rare time where we have to go to command and control and say, now you must do it for the greater good of the community, to preserve the infrastructure, for the health of everybody. Now we have to do it. It's no different than World War II, where you try and incentivize people to sign up for the Army and sign up for the Navy and all that, but you get to that point where, like, you know what, we're instituting the draft. Now we're going to tell you that you need to go fight for your country because we don't have another choice. Very similar. That's because it was a optional, or it was a voluntary thing. It was considered protected health information. We were not allowed to ask them that information. So we have some, because of how the vaccine got rolled out, and we got that initial shipment that was meant just for our staff. We have some idea at least how many we did then, and so we've got a rough estimate. But no, we don't have the exact number yet. Right now, we are asking people to give us proof of vaccination because of the mandate. Just in the last 24 hours, we had 200 additional people send us their proof of vaccination, so we're starting to get a little bit of an idea. But we aren't going to know probably until October 4th or so, when you hit that that last deadline for the second dose, probably, how many that number actually is.
If you're, can I ask a question? If you're taking the kind of drastic steps that you are now, where are you going to be a month from now, 2 months from now?
Well, that's why we're in this emergency command mode, because right now all you can do is focus on the last 24 hours and the next 24 hours. So on Wednesday I got asked, well, what's the worst case scenario? Let's just talk about that oxygen. So as I already told you, we're having to monitor our oxygen supply and our ability of our infrastructure to support that oxygen. We're okay at the moment, but it won't take many more patients to overwhelm that, and then we're going to have to move towards either finding additional space where we have different oxygen supply lines to use it, or you have to move to oxygen tanks. Because this isn't just us, this is the entire country, and a lot of us are on the same trajectory. What's going to suddenly happen if we get there is there's going to suddenly be an awful lot of hospitals with the same problem who are all asking for those same resources. And those are finite resources. And when that happens, that's when you go into what's called crisis standards of care. It's the place we never want to get to. That's where you're going to be cared for by somebody who's not trained to care for you. We're going to be saying, hey, Jennifer, you're an admin assistant. Guess what? You're now taking care of patients. We're going to teach you the bare bones of what you need to do to take care of a patient, and you're going to help us out. It's when you start having people who are not critical care doctors take care of critical care patients. And it's when you're going to have to decide, okay, I've only got so much oxygen, you, and you get it. I'm sorry. Based on your health profile and your likelihood to survive, you're not going to get it, and you're going to be comfort measures. That's the nightmare scenario. That's what we want to avoid.
The way things are now, would you say that this is definitely the crisis that you guys are?
That's the next step, is this what we call crisis standards of care. There's a lot of, there's calls at the state level and the regional level, kind of continually assessing where the hospitals are. But when you start to see hospitals turn classrooms into patient care areas, when you start to see them, closing clinics and moving staff in, when you start having to put appeals to the community for retired people to come out of retirement to help you, that should be a pretty loud warning that we're getting there, that we are maxed out on our ability. So ideally you operate in what's called conventional capacity. These are terms you can look up, they're pretty well adopted. Conventional capacity is your normal daily operations. That's what you should be in pretty much all the time. Then there's what you call contingency capacity, which means you can still use the same personnel, the same resources, you just have to put them in, use the PACU, use infusion care to hold patients, that kind of stuff. That's contingency. But then once you overwhelm that, and now you're talking about, putting a tent up in the parking lot where you have no, oxygen lines, and you're using personnel who aren't really trained to take care of this, that's when you're in what's called crisis capacity, and that's really a state decision to go into that mode.
Dr. Brueggemann, kind of shifting gears in regards to the air quality with the smoke and everything. There's that downtown Yakima Mile going on tomorrow night. What are some of the risks and dangers people that might be participating and or watching the event?
Let me start by saying I'm glad that's an outdoor event, because all my mind can think about right now is all those people gathered together at a time when our community transmission rates are around 30%. Fortunately, being outside definitely dramatically lessens the risk of that. In terms of the air quality, what's interesting is if you wait a couple hours, it seems to change a little bit. So we'll just have to see what the conditions are. But yeah, if it's smoky, they'll absorb more of the smoke particles. It's really just, if you think about it, when you're moving faster, breathing harder, you're taking in more of it's going into your bloodstream. And so that's why they recommend generally you don't run and exercise and stuff when the air quality is really bad. My guess is most of these are probably pretty young, healthy people who probably are going to tolerate it pretty well, though.